Noman, consultant infection control. I'll be talking on Middle East Respiratory Syndrome lessons learned. Middle East Respiratory Syndrome is a viral respiratory disease caused by a novel coronavirus MERS-CoV that was first identified in Saudi Arabia in 2012, initially called novel coronavirus 2012. Coronaviruses are a large family of viruses that can cause diseases ranging from the common cold to severe acute respiratory syndrome. During the summer of 2012 in Jeddah, there was an unknown coronavirus isolated from the sputum of a patient with acute pneumonia and renal failure. Shortly thereafter, in September 2012, there was another unknown virus isolated from a patient from Gulf region. The both were identified to be the same virus. Already in April 2012, if it was traced back, there were a cluster of pneumonia cases in Jordan, which were found to be the same virus. So this virus in 2012 were called novel coronavirus 2012. This virus had sustainability of transmission in human to human. Next year in 2013, at least 34 lab identified cases were reported. The infectivity was low, especially the secondary transmission was very weak. However, the mortality rate was very high, reported up to 60%. We will be talking on the salient feature of the presentation and behavior of the virus from 2012 through 2015. Now, if you see this bar chart, it shows 3 years, 2012, 2013 and 2014. Most of the cases are from Saudi Arabia. In 2012, there were sporadic cases. In 2013, there were cases in the range of 20 to 40 per month from month of April to September. However, in 2014, there was a sharp rise in the month of April, touching more than 200. So outbreak in 2014 was announced, and there were large number of fatality was expected next year. Now you see this another bar chart, again the same 3 years. Observe the blue color showing the primary cases. So just look at this outbreak in 2014. These were the primary cases, and there were more of the secondary cases in the month of April and May. Ministry of Health of Saudi Arabia took all the precautions and other necessary actions to reduce the risk of the virus spreading. They worked jointly with international specialists and organizations like WHO and CDC. The work included but were not limited to revised guidelines, MERS-CoV assigned hospitals in different cities of Saudi Arabia, training of healthcare workers, improvement in the surveillance system all over the country, detailed study of cases and the clusters, and other research work. The case definitions include suspected cases, confirmed, and probable. A confirmed case is a suspected case with laboratory confirmation of MERS-CoV infection. Suspected cases include the patients who should be tested for MERS-CoV. As per the guideline of 2014, there were 4 case definitions for suspected cases within Saudi Arabia. The first definition was a person with fever and community-acquired pneumonia. The second definition was a hospitalized patient with healthcare-associated pneumonia. Third definition had 3 criteria. The first criteria was acute febrile illness. The second was body ache, headache, diarrhea, or other atypical symptoms. And the third was unexplained leukopenia and thrombocytopenia. All these 3 criteria has to be present to fit in the case definition number 3. The fourth case definition was for healthcare worker who had either protected or unprotected exposure to a confirmed or probable case of MERS-CoV infection. And during the next 2 weeks of exposure, they had either upper or lower respiratory illness. A probable case was a case with inconclusive lab result. It might be a close contact of lab confirmed MERS-CoV case, or a patient who worked in a hospital where MERS-CoV cases are cared for, or had a recent contact with camel or camel's product. However, for any patient outside Middle East, exposure criteria was also required. There has to be a link within the 14 days prior to illness to the affected area. Either he had been a resident or had a travel history, or he had a close contact with someone who was a probable or confirmed case, or a traveler or resident to the affected area. Clinical and public health judgment should be used in assessing patients with milder or atypical presentation based on contact, comorbidity, or cluster history. The index of suspicion must be raised. Now this bar chart is different because now it includes 2012, 2013, 2014 and 2015. As we have seen that in 2014 there was a large outbreak in the month of April and May. However, it was controlled. Next year there were cases from January and February. However, the last 3 years there were no cases in month of January and February. So during month January to March, it was suspected that because there were at least 14 identified clusters and at least 46 cases during these 3 months, so even more cases were expected in the coming month. Among these, that most of the transmission was in the healthcare setting. However, some were also in household. Now look at these two line charts. First, observe the red one, which shows 2014. Again, this high rise in the month of April and May. Then it went down, a slow rise in the end of the year. In next year, 2015, there was higher cases touching or crossing 20 in the month of Feb and March. Then it went down and it never rose above 20 cases, and still the cases are down. Now we will answer few of the important questions. Is this virus fatal? Approximately 36% mortality rate is reported. Fatality is not same. 36% mortality does not mean that out of 100 identified cases, 36 will die. The fatality differ with patient with underlying condition, like people with diabetes, renal failure, chronic lung disease, or those who are immunocompromised have a higher risk of disease and death. Now look at this bar chart. First observe the blue color. This shows the cases with underlying disease. However, here are the cases without underlying. There is a wide difference, 85 versus 26. Now look at the red chart, which shows the death in those with underlying disease versus those without underlying disease. But 45 cases versus no case report in those without underlying disease. So the underlying disease was somehow put them more risk for death. What is the source of this virus? Majority of human cases of MERS have been attributed to human infection. Camels are likely to be a major reservoir host for MERS-CoV and an animal source of MERS infection in human. But the exact role of camel in transmission of virus and the exact route of transmission are still unknown, and work is being done on that. Early research have suggested that Egyptian tom bat was the actual natural reservoir. And the research work has also shown that last 2 decades, around 90s, this virus has been circulating in the camels. They have acquired it from the tom bat. And from the camel in 2012, it was transmitted to human. For evidence of camel being the primary source, in November 2014 to May 2015, there were 194 cases studied. Out of them, 29% had either direct contact with camel. Evidence of camel as a primary source. Between November 2014 and May 2015, out of 194 cases, 29% had either direct contact with the camel or they drank raw camel milk. There are another two examples which are evidence of camel to human transmission. The first was the case of a patient who died of lab-confirmed MERS-CoV infection after close contact with camel which had rhinorrhea, and the same MERS-CoV virus was obtained from the camel as well as the patient. Another patient who had 9 camel and one of his 9 camel was positive for MERS-CoV RNA. Now look at this pie chart. The blue color shows the primary community-acquired confirmed cases, which comprise 57%. However, the green and the red one show the secondary cases. The green one is the secondary which were acquired by the healthcare worker while taking care of the patients. And the red one are the other patients who were present in the same healthcare setting. So the focus was both way. The number one was on healthcare setting and the other was in the community where one of the major source was camel. If this virus were airborne, although as a coronavirus for MERS-CoV in the earlier guideline, the standard and droplet precautions were stressed, and airborne precautions were recommended only for confirmed cases and for aerosol generated procedure. However, in later guideline, airborne precautions were recommended for all suspected and confirmed cases, and it helped a lot. Traveling, although many cases have been reported when the individual who developed MERS-CoV had a travel history from Middle East, yet no travel bans to Kingdom of Saudi Arabia have been enforced by any country. WHO has not recommended any travel restriction to or from Kingdom till now. Hajj and Umrah are the religious ceremonies of the Muslims which are performed in the Kingdom of Saudi Arabia. And you can see that during these ceremonies, people come very close to each other and there is a very likelihood of transferring of MERS-CoV. Yet, the Ministry of Health has not issued any advisories regarding Hajj or Umrah. There have been no outbreak or cluster cases reported during Hajj or Umrah. But based on the current medical consensus, some people who are at high risk are advised to postpone their trip. On everyone must take the precaution by following the preventive guidelines. Is this virus seasonal? The April 2014 report shows that the occurrence of new cases seems to follow a seasonal pattern with increasing incidence from March to April. Yet we have seen that year 2015 did not follow this pattern. Afebrile patient. Although we have seen that the case definition of suspected patient in 2014 guideline, all the definition had fever as one of the important criteria. But by MOH data, there were many cluster cases of afebrile patients who were found to be MERS-CoV positive. Therefore, the case definition of suspected cases is modified to include afebrile patients. In the latest guideline, you can see the case definition 1, which has been modified. It does not say fever, it says acute respiratory illness with clinical or radiological evidence of pulmonary parenchymal disease. Rest are the same. Which age is more at risk? Again, when we studied last year's, most of the cases were above 20 and there were no case reported of pediatric age group under 20. So it was considered that pediatric age group under 20 were at very low risk. We can see that all the cases identified were above 20 to 24. Most of the cases were from 45 to 69. But again, when in early 2015 we had many cases of pediatric patients, so now the latest guideline have been modified. And now for the suspected cases definition, there are two definitions for pediatric age group. Number one, it meets the above case definitions and has at least one of the following: either history of exposure to a confirmed or suspected MERS-CoV in last 14 days, or a history of contact with camel or camel product in the last 14 days. The second definition is unexplained severe pneumonia. As we have seen that in 2015, the cases start going down after April, and they were almost touched baseline level, and there were few weeks where there were no case report all over the world. We were just expecting that this outbreak has gone down. But in May 2015, Republic of Korea had an outbreak of MERS-CoV. May 20, a 68-year-old man who was returned from a trip from Middle East led to an outbreak. This outbreak spread in a healthcare setting. The first fatality occurred in early June, and till July 5th, there were 185 cases and 33 deaths, and all were traced back to the healthcare setting and traced back to this individual patient. This is the updated 6th July 2015. We can see that the total cases were 1,381. Out of them, 1,062 were only in Saudi Arabia. There were 520 deaths with 460 in Saudi Arabia. The second two largest is in the recent South Korea outbreak. United Arab Emirates had 78 cases with 9 deaths. All others have fewer than that. We have yet to learn a lot during the coming years, and this is what the message we are getting for MERS-CoV. Thank you.